Nick Majerison here. Welcome to Top Med Talk. Now, before we get cracking, Top Med Talk is going to be at the International Fluid Academy Day on November the 23rd in Amsterdam. Full details, topmedtalk.com. Click on the section marked Events. You'll be able to find out more. It's on November the 23rd. It's in Amsterdam. It's the International Fluid Academy Day. Going to tell you more about that towards the end of the podcast. In the meantime, it's time for today's Top Med Talk. And today's Top Med Talk is called Treating Preoperative Anemia with IV Iron is Safe and Effective. It's part 2 of 3, and it's about standing up a perioperative anemia clinic, taken from the EBPOM USA Masters course of Perioperative Care Practicum, which was, of course, streamed live here on Top Med Talk in April of this year from Atlanta. This is part 2 of 3, and it goes like this. Let's have a listen.
Top Med Talk.
Okay, so we know that presurgical anemia alone is associated with increased morbidity and mortality. We know that presurgical anemia is actually the strongest predictor of need for blood transfusion. It's not what your surgery is. It's not who the surgeon is. It's actually what your starting hematocrit is. And we also know that blood transfusion is associated with an increased morbidity and mortality in a dose-dependent manner. So what do? Well, the answer is that we diagnose and treat preoperative anemia. So you come up with a brochure like this, and you start an anemia clinic. So it's very important to know that our preoperative anemia, it's very different. We are not an anemia clinic. We aren't there to treat patients' thalassemia and patients' myelodysplasia. We are there to detect the preoperative anemia and to get them ready for surgery and strong for surgery. It's very important that these patients always get sent back to their primary care doctors, because iron deficiency anemia, as I'll share with you in a moment, is the number one treatment and diagnosis that we see in preoperative anemia. And it's also a marker for colon cancer in any postmenopausal woman and in any man. So always refer back to the primary care doctors to get that evaluated. So the diagnosis of anemia and the algorithm for figuring out what's going on with patients has really 2 branches. You either don't make enough red cells, or you destroy those blood cells or lose those red cells. There's just a couple things you have to know about treating preoperative anemia. So really, iron deficiency is the mainstay of preoperative anemia, and that's about 30% of our patients, and they're for a variety of reasons. Patients don't eat that well. Patients have blood loss, so they've had a surgical procedure before that. They've had phlebotomy, and mostly they've had impaired absorption. And the idea is that getting iron into your body, which is really that maker that we need to make red cells, is really tough in humans. So our average stores are about 1 to 3 grams, and we lose iron every day. The way we get iron in our body is really reuse of our red cells. So the red cells live about 120 days. They die. Our macrophages eat them up. They use up the iron, and then we put the iron back in more red cells. So any patients who have had any sort of blood loss, so they've just had their other knee done or their other hip done, or they're menstruating, they're not going to have availability of that iron. In addition, our diet, it's really hard to absorb that iron. So anything like antacids, so patients on proton pump inhibitors or patients on H2 blockers, they're not absorbing iron. So in order to absorb either your supplement or your oral iron, you need to have an acidic environment. So most of our patients don't have that. In addition, these phytates and these tannins, things in red wine and nuts and whole grains, you don't absorb iron. So we start with iron replacement for our patients, and I really feel that there's no role for oral iron. Some centers will give oral iron or a trial of oral iron. I find that patients don't like it. They won't take it. They have to take it twice a day. It's tough. And so IV iron is such an easy, relatively inexpensive thing to give, and patients feel so much better after you do that. So the effect, you start to see it at about 1 week. It peaks at 2 weeks, which is well within the range of preoperative management. And there's different preparations, which we can talk about later. So how much iron should I give? Well, there's a formula that's based on their body weight and what their hematocrit is and what you want their hematocrit to be. But like anything else, there's an app for that. So you can get an app, or you can just search it on Google, and there's an iron deficit calculator. You put in what you want their crit to be, you put in their weight, and it'll tell you how much iron you should give. The other thing you should know, that it's a 1-to-1 loss. If someone's just had their hip done or their knee done, and their anesthetic record or their surgical record says they've lost 800 cc's of blood, that's an 800 cc deficit of iron that you need to give back. So the next most common cause of preoperative anemia is anemia of chronic disease or anemia of inflammation, and that's about 1/4 of all of our patients. And this is an interesting disease, and I know you've all seen it before, but it's really regulated by this molecule hepcidin that's made in the liver that gets made a lot of when patients are ill. And what that does, it hits iron in two different ways. So one is it doesn't let the iron out of the macrophages, so after your red cells die and you use up that iron, it doesn't let it back in the system so you could use it. And you also don't absorb it as well. And the other thing that happens is that erythropoietin, that hormone that's made in your kidneys normally that tells your body to make more red cells, it actually doesn't work as well when you have anemia of chronic disease. So it's hitting it twice. One, it's not letting us use our iron to make red cells, and the other, it's not allowing us to be responsive to that erythropoietin. So we hit anemia of chronic disease in two ways. One is that IV iron again, because even if their ferritin, and we'll talk about iron studies in a moment, but even if their ferritin and their stores look high, it's not available to be used for red cells. So we give IV iron for that, and then we give erythropoietin or ESAs. Procrit is our drug of choice just because the onset of action is pretty fast. And it's interesting to note that our ASA guidelines, our anesthesia guidelines, actually in 2015 tell us that we should be using EPO for these patients. Erythropoietin should be administered when possible to reduce the need for allogeneic blood in certain populations, including Jehovah's Witnesses and anemia of chronic disease, which is a lot of our patients. Perioperative ESAs have been approved for use with autologous donation for a long time, since the 1990s, and even without autologous donation in the late 90s. Our guidelines, your guidelines for Medicare guidelines are going to be different region to region. Ours are all elective hips and knees can have EPO. Medicare will pay for EPO if their crits are less than 39, even for a woman. So if your crit is 38.7, Medicare will pay for them to get 4 doses of EPO and get their crits up. All other types of surgeries that are not elective hips and knees, at least in our region, their crits have to be less than 30. Actually, they've lowered it to 30 now. It used to be 33. They can't be iron deficient. If you code for an iron deficiency anemia, Medicare's not going to pay for it. And you want to make sure you always give iron with the ESA, because even if they're not iron deficient, once they start making all those red cells, they're going to need some IV iron. This is just a study showing that it does work. It gives it in a different way than we give it. We usually give it once a week for 4 weeks, or 3 to 4 weeks. This was giving it 9 days pre, and it shows that if you give it pre-op, your crits will come up, and it'll stay up after the surgery. And if you don't give it down here, they're going to be lowered at the surgery all the way through. And again, this is just looking at allogeneic transfusion in patients in the control population in orthopedic surgery, getting EPO and not getting EPO, the percent of patients who needed a transfusion. So EPO, you may have heard, has gotten kind of a bad rap since 2007. It has a black box warning on it, specifically for patients with cancer. It's thought to be that some cancer cells have EPO receptors, so the FDA decided to regulate that. And the one that affects us is that in peri-surgery, it says it does increase the risk of DVT, so we do have to be careful about that. It's interesting, this regulation, this black box warning about EPO and cancer, and FDA did put this on there, and it has limited how the oncologists practice. If any patient going for a cure for their cancer therapy, they're not supposed to get EPO anymore. As you probably remember, before this black box warning, every patient undergoing chemotherapy was on EPO. But it's interesting that when you actually look at the studies that they showed, the meta-analysis of 60 studies, there was actually no effect on mortality or disease progression. So why is it that they limited us? Well, of the 60 trials, if you actually look at them, there's only 8 that are responsible for the safety signal that got us this black box warning. But if you look at their crits, what they were going for in these patients, and these are not perioperative patients, these are cancer patients, but all their crits were greater than 45, 42 to 45, which is not what we're aiming for in preoperative anemia management. That said, with cancer in our population, because of the way our centers run up and we have protocol-based, if patients do have a history of cancer, we are limited in how much we'll give them, and we do have a very frank discussion with our patients about it. So the risk of EPO and thrombosis is real. This is a randomized controlled trial with spine patients. But it did show that the rate of symptomatic DVTs was the same, but the overall rate of DVTs, if you look with an ultrasound, it is higher in EPO. So we do make sure our patients are either on mechanical support for prevention of DVT or chemoprophylaxis. So the summary for EPO, we use with caution in kidney disease. and malignancy and history of VTE, the kidney disease, because they're very well regulated with their EPO and they can get in the renal center. And that said, with patients with end-stage renal disease who are on dialysis, we usually take that out of the hands of the nephrologists. The nephrologists are very stingy with their ESAs, and so their goal is to get the crit of 30 for their end-stage renal patients. So we will push them higher, and so we usually tell them not to get their EPO dose when they're having dialysis. We send them to our anemia clinic, and we have different regulations for that, and we usually run our crits higher for shorter periods of time. You're going to use the lowest dose you want, the lowest dose you can use. We're going to give it with IV iron, and we're going to often use some chemoprophylaxis for a DVT. So other causes of anemia, chronic kidney disease, which we just talked about, low endogenous EPO for those patients, and then phlebotomy and angiograms. Hopefully at all your centers you've stopped doing a lot of your femoral angiograms. We found that patients were usually losing about 5 to 8 points in their hematocrit after their femoral angiograms. We're all cathing them now radially because of this. Okay, and this is our algorithm here. This is the very similar to how we do it, but this is the National Association for Transfusion Guidelines and how they run their preoperative anemia. It's actually quite simple. If someone's anemic and they're coming for surgery, we check their other cell lines. They have to have a CBC within a certain amount of time, but if they have a problem with their platelet count or their white count, then they will get an automatic heme consult because that's usually something else going on. If it's just their red cells that are low, then we always check iron studies, and so that's the first thing we do. If they're deficient and we have no obvious source for that, then they need to have a GI workup, and so we make sure that that's going on at the same time that we're treating them and getting them ready for surgery. We make sure we don't stop the whole process for surgery. We're still continuing with that to make the surgeons happy, but we also start giving our IV iron. If they're not deficient, then we will check the renal function. Oftentimes, any GFR less than 50, your EPO isn't the same. So any GFR less than 50, they're going to need some EPO. We might check a retic count to see what's going on, and then we're going to give them ESAs. So this is what we do. The most important thing is that we need to know about these patients. So we hit the surgeons hard. We tell them that you have to send us to our pre-op clinic. We have to know about these patients. As soon as you're even thinking about surgery, please let us know, and then we'll take it from there. It has to be very easy for the surgeons. They can't have to act. You know that they don't want to do any extra work. So as long as we know about them, we take it all from there. We send off iron studies, and then we'll give them their iron and their EPO. So this was our experience. We started it in 2007. It correlated with the opening of our orthopedic hospital since we had that nice subset of patients with a set DRG between their elective hips and knees. We decided to staff it with a pharmacist. And I don't know of any other centers that do that, but the reason we do it this way is because a lot of these patients need pre-authorization to get it paid for. And the pharmacists are very well acquainted with that whole process. So by having a pharmacist in there to do that whole pre-authorization, we avoid all the hassles with billing later. We have a medical director, and we started by treating orthopedics, OB patients, and heart patients. In 2014, we opened an anesthesia clinic, and so our pre-admission clinic run by anesthesiologists. So now we still have our pharmacist in there helping us get pre-authorization, and we treat all of our pre-surgical patients, so every patient coming through. And this is what happened early on. So this is for our orthopedic patients transfused. We went from about a 60% transfusion rate down to 8% in a year. And this is looking at just following up from there, transfusion rate here from 8% down to 2% in 2013.
Top Med Talk.
This is taken from the hugely successful EdPOM USA Masters course, Perioperative Care Practicum, which took place in Atlanta earlier this year. I mentioned at the beginning of the podcast, we're going to be covering the International Fluid Academy Day on November the 23rd in Amsterdam. Now, this is a great opportunity for you to meet the team if you want to come along. All you need to do is check out the website, topmedtalk.com, click through to events, and you'll find a full piece on the website detailing everything you need to know about the International Fluid Academy Day, November the 23rd. Now, we've set up a Slido account for people who want to interact with us and our guests during the International Fluid Academy Day. Here's how you get to that. Go to slido.com. I've got a login for you. It's hashtag TMTIFAD 18. So IFAD, International Fluid Day 18, and TMT, of course, standing for Top Med Talk. So that password, once again, slido.com, hashtag TMTIFAD 18. So TMT IFAD 18 is an easy way of remembering that. You can get onto there, put your question in early and have a chance of having it answered sooner rather than later. Don't forget that login, TMT IFAD 18. That's hashtag TMT IFAD 18, and that's on slido.com. And then, of course, if you think you can come along to the day itself, that'd be great. We'd love to see you. Amsterdam, November the 23rd. Go to the website, topmedtalk.com, and click on the section marked Events. Also, of course, you can download our full back catalogue at the moment here on Top Med Talk. All you need to do is go to your podcatcher and click Download All, or scroll through them individually and clicking Download on each one, or go to the website topmedtalk.com and explore our back catalogue, downloading as many as you can. It's entirely free. You can get all of the back catalogue at the moment. We're currently sorting through it, so it may not always be available in that form. So get yourself to the website topmedtalk.com and download all of our podcasts, our entire archive, whole back catalogue, many hundreds of valuable podcasts with incredible information within.